Good morning, everybody. I hope you're fit and that you're looking forward for today and this exciting workshops and interesting lectures. And yes, we will today learn something about the RUSH and the eFAST protocol and then apply everything directly in the hands-on sessions. With that, I would like to introduce our first speaker now. Aleks Sustar is currently working as an emergency medicine resident at the University Medical Centre in Maribor in Slovenia. He is passionate about ultrasound as a diagnostic tool, and today he will give us a very interesting lecture about the theoretical background of the eFAST protocol. After the hands-on session, he will continue with clinical cases referring to this protocol. Big applause for Aleks Sustar.
So everyone, hi, good morning. I'm very pleased to be here with you and to excite you about ultrasound and the use of the FAST or eFAST in emergency medicine, which is something that I have actually found it's really, really useful. Just a quick background where I work up there. This is the emergency center before COVID and now after COVID. So it's kind of expanded with all the tents and shitty stuff like that. But otherwise, first of all, thank you very much for inviting me to come here. I would like to also maybe just shortly present, this is the team that I work with. There are quite a few residents, and we are all really, really passionate about ultrasound. It's not like everyone that comes in here in the emergency department gets a fast scan. No, you have to have indications. This is why we actually first, when you see the patient, have to ask yourself, why would you do an eFAST or a fast scan? Like, what are your ideas? I was thinking that this could be a bit more interactive. So who would you do an eFAST scan on? Trauma patients, yeah. Do we know what an eFAST actually includes? Like, what's our question or what's our clinical thinking? Yeah, free fluids, mostly where they shouldn't be, and free air, okay? So this is all, let's say, pointed towards identifying something that shouldn't be there, and then this leads on to our actions. So, for example, if we have a mentioned trauma center, trauma patient, which has free fluid in the abdomen, this is something that we should identify because this is something that this should be operated on. Then if he or she has free fluid in the lungs, it's also something that needs to be taken action on. So it's always think action oriented, okay? And also you have to think when you work with eFAST, because first of all, FAST has been here like since the 70s. And then in like 2003, 2004, they added the E part, which is also like the part of the pneumothorax. You have to think, when your patient comes in, what are the possible causes of his, let's say, mechanism? So what are the possible causes that this patient actually encountered? So we set indications, so trauma patients, anything besides trauma patients. Who would you do an eFAST on? There are no wrong answers. Like if you say you're going to do it on me, sure, but like it's not going to be really helpful for you. I hope so. I hope I don't have any free fluid inside. Oh yeah, sure. Anything else? Shock, yeah. For shock, the RUSH protocol is much better because it identifies the points of shock, but in shock for sure. Acute abdominal pain, perfect. This is something that we sometimes forget because a lot of times, like if we have like an elder gentleman, like in their 70s, acute abdominal pain, what would be the possible cause of a free fluid in the abdomen? A rupture of abdominal aneurysm. So you have to think about that. And then if you have someone who is dyspnoic, again, where could he have free fluid? Yeah, here, okay? So this is always what you have to think about. So we talked about blunt trauma and penetrating trauma. Like for here, if you have someone that has a few knives inside him, I don't think you have to look for free fluid. There's probably gonna be free fluid inside, okay? In blunt trauma, you have to think about it and you have to perform it. And then we talked about non-traumatic causes. One that you shouldn't forget, and I will talk about this in the cases afterwards, is also in young females. Why? Yeah, let's say, but pregnancy, but ectopic pregnancies. So kind of like if there is a rupture there, and we'll talk about one of the cases like this afterwards in the cases part. I mentioned that you have to ask yourself, is there air for the pleura, and is there fluid? These are the only two questions that you ask yourselves. Don't ask yourself, what is the morphology of this kidney? Like, this is not your task to identify in eFAST, okay? You have to think about what's there and then to move towards your actions on what do you do. Always make a clinical workup. So when we said an elder gentleman with an abdominal pain, my clinical workup is, okay, acute abdominal pain, my differential diagnosis is ta-ta-ta-ta-ta-ta, and then afterwards I'm gonna do an eFAST because I want to identify or exclude this, okay? I've just listed a few things that we talked about here, just like this is always the way that you have to think when the patient comes in. If you have this sort of thinking, an eFAST is gonna be really helpful for you. Okay? And just like not to complicate stuff too much, you have 3 main points or 3 main spaces you have to look into. The first one is already shown here. And which space is there? Is this? Sorry? Yeah, so you have to look at the heart first. Why? Why do we start with the heart in eFAST? Because this is gonna kill you first, okay? If there is free fluid inside the pericardium, if there is a tamponade, this is something that's gonna kill you first, okay? The second thing that we look at is the abdomen, okay? In abdomen, we look where? You probably read some background on eFAST, correct? Yeah, okay, so where do you look in the abdomen? 3 spaces? Yeah, perfect, where's Morrison's pouch? Can you just stand up and show me?
Yeah, between liver and kidney.
Yeah, perfect. This is one space. Second one. Like here, do you want to look? Here, here, here. Yeah, okay. So you have to look around the spleen. And the third place. Yeah, perfect, pelvic, okay? Don't forget, you have 2 different orientations in the pelvic part. Maybe just like one guideline, what you should think about is don't be happy with just like pointing the probe at the patient, identifying the Morrison pouch, and saying, yeah, there's no fluid, that's it. Most of the times, what I've seen, it's not just in the Morrison pouch. You have to look around the liver as well. It can be above the liver. It can be like just a tiny bit of free fluid, and just scan it. I'll show it to you in a few minutes later. And if you have a high suspicion that there should be free fluid and there is not free fluid there when you check it, what do? Recheck it, yeah. Just like think about why FAST is so good. Because I don't think there is a contraindication except someone having like several knives inside them. Like there is no time for you to do the like full FAST examination, but you can repeat it as much as you want to, okay? Because there is no malign, radiation, yeah, this is the word I was looking for. So one space, second space in 3 different projection, and third space, this one that has been added, which is, yeah, perfect. So I have to look at whether there's air. When you look at Morrison's pouch, you, of course, also take a bit of a peek inside whether there is some fluid a bit higher, so above the diaphragm as well, okay? If you, during the eFAST examination, manage to find something else, this is something that you just take note and then come back to it afterwards, okay? If you see, this kidney is like really interesting, or there's something like really wrong with it, don't focus yourself too much on that. So just like think about the questions that we asked ourselves before. So what I would now go to, Chris, can I ask you to come here? I think it's best for you to just see like how to perform the eFAST and to see like what are the caveats or how can you actually do this. So first of all, for the probe selection, what would you select of these probes? The one in the middle, yeah? Why not this one? Not deep enough, yeah? Okay. Why not this one? You can also take this one, okay? For me, this one is really useful when I do the heart examination because it's much easier to project the heart. But otherwise, I'll show everything with both of the probes so you can see what differentiates here. So first of all, when the patient comes in, he's usually not like Chris. I mean, on Chris, I wouldn't do the eFAST examination. How would you position the patient? On the back, yeah? Can you lie down? What about, like, can he be like a bit raised or like a bit lower? How would you position the patient to have the optimal results for your examination? Lower or higher? Flat, okay. Yeah, mostly flat. Some people also suggest to kind of like put it a bit like that towards the head to feel the Morrison a bit more, but like the 5 degrees ain't gonna do much of a difference, okay? So just like flat on the back. Where do you position yourself as an operator? Where there is space, okay? Because usually this is not like a calm environment where you can do the eFAST examination, but you just position yourself where there's space. And we talked about contraindications. So we talked about this part, and now I'll go through every single part. On every part, I'll be projecting the, let's say, normal picture, and then I'll show it on Chris as well. So first of all, what we're going to start is this point. So what are we looking for at this first part is the heart. Can I project the ultrasound now? Okay. One point, there is never too much of gel. So just use all the gel you have. Okay. So we select our probe. Here, cardiac. Okay. Can you see it? Okay. So first of all, when you do this view, don't do, let's say, the thing, well, the most common mistake that people usually do. When they do this projection, they try to place their hands like that. If you're going to place your hands like that, what are you going to see? You're not going to see the heart, because the heart lies where? A bit like that, okay? So just like take your probe like this, use the orientation to your right, go here, and then you're going to see the heart here, okay? Sometimes, just like adjust the depth a bit, okay? And sometimes the heart is not going to lie in this position. Sometimes you're going to have to move the probe around and scan a bit more. Can you see it up there? Yeah, I know we can see it down there. Okay, so I'll just blabber a bit more while they try to fix this. Otherwise, you can, like, if it's not going to be possible, you can come here and take a look at this here. So yeah, when you use your probe, don't place your fingers in this projection. Don't place your fingers or your hand below the probe, okay? Just use it like that and just sink it inside the patient a little bit, okay? How is it working? Not yet, okay. So what am I looking at in eFAST here? What am I looking for? Yeah, pericardial effusion. Is every pericardial effusion dangerous? Yes, no? No, okay. This is what you have to think about. In trauma patients, most of the time it is, because it represents active bleeding, okay? It can be either due to rupture of the aorta or the, let's say, rupture of small vessels or something like that. But you just think about the possible causes. If you see free fluid inside the pericardium around the heart, in trauma patients, repeat the exam if it's just a little bit, because this can increase in a few minutes, like really, really fast. If it's not going to be possible, I can maybe just like ask you to come around me, or maybe like around that computer or this computer and some people around me, because it's important for you to see it. Can you maybe like come closer so you can see what I'm trying to show? Is that okay? Yeah. Maybe like a few people can come here, a few people can come there, and I think on the other computer it's also visible. And when I'll change the probes, I'll just show you everything, okay? So when you place the probe, if you place it, as I was talking before, if you place it like that, you're not going to see anything, okay? So just press it like that and gently sink it inside the patient, okay? What do I see now? Can you identify the structures? Anyone? Yeah? First of all, like, what do I see? Like, what's the highest thing there? The liver, yeah? Perfect. Then we have? Which one is the left and which one is the right? Which one is this one? Right. How do I know it's the right one? Next to the liver. Exactly, because it's next to the liver, okay? So identify the structure. So we said liver, and then we have the right ventricle, the left ventricle, and we have the atria, okay? This is it, what we are looking here at the eFAST examination. You don't take a look at the vena cava, you don't look at the other structures, but just the heart, okay? If I take a look at the same projection with the different probe, okay? This is the view that you're gonna get. The orientation of the probe is the opposite to the cardiac probe, okay? To get the same image. Again, put the probe in and just sink it into the patient a bit. Again, what do I see? Let's identify the structures together. So this is, yeah, perfect. This? Okay, and this? Okay. Where would the free fluid be here? Yeah, perfect. Why? Why it's the free fluid? Why it's usually in, we are talking about trauma patients usually. Why is the free fluid here?
Because the pressure is the lowest.
Exactly. Because the free fluid, it's usually here or in the apex. It's not in the here around the left side of the heart. Because the inside pressure of the ventricle is much higher in the left ventricle compared to the right ventricle, okay? So if you just place the probe, that's okay, but then you have to scan a bit, okay, as well. Just take a look at the heart, take a look at the apex, take a look at the whole of the right ventricle, where you would expect most of the free fluid to be, okay? This is the first part that you get. Then I'll continue with this probe. We talked about the second part. you remove just the, no, you can leave the hands here. Just remove the hands of the patient a bit and place the probe where? Where do we continue the eFAST examination? On the right side. So we talked about the Morrison's pouch. So when you place it here, like what are we looking for? What are the structures that we're looking for? Liver? Yeah, do we see the liver? Yeah. Okay, now I'm gonna be a bit of a troll. Like, if I place it like that, why is this image not good? I have my probe like that, okay? Why is this image that I have right now here not good? Do you see any shadows? Why are there shadows? Because of the ribs. How do I eliminate the shadows? I twist the probe to go inside the ribs, okay? So if it's like that, and if I twist the probe, no more ribs. Perfect, okay? So then I have the liver. Am I happy with the picture now? What am I missing? Kidney, perfect. Where's the kidney? If I look at this, what do I see? Is this free fluid? No. Yeah, that's the gallbladder, okay? So don't confuse the gallbladder with free fluid. What do you have to see? Like, if you see the gallbladder, you're a bit too high, okay? So go lower, okay? Okay. Do you see it here now? Okay. Where is the Morrison's pouch? Yeah. I can't point it like that. Can everyone see where I'm pointing? Yeah. Okay, so this is the Morrison's pouch. Usually the free fluid will be here. But again, don't be happy with just placing the probe and see it, okay, there's Morrison's pouch, it's free fluid, okay? This is not okay. If you do the eFAST examination, when you place it like that, this here, scan it a bit, okay? Just scan with fanning of the probe a bit. Then maybe turn the probe as well to scan around the kidney. This is also Morrison's pouch, okay? It's just a bit different projected. Do not forget, and I'll talk about this in the cases afterwards, about this part of the liver and this part. So here, okay? This is what like free fluid could look like, but this is not free fluid. This is a projection of the colon, okay? So if you take a look at this, take a look at this here, and do not forget to take a look at this part, so behind the diaphragm, below the diaphragm. Here we also said that you take a look at what? The lung, okay? So how do I know that there is no free fluid here? When you see liver here, okay? So when you see the diaphragm, you have the mirroring effect, and the liver kind of translates into the lung. If there is blackness there, or if you see like a small octopus waving, this is usually the lung that's drowning inside. I'll show you the videos later so you can see it. Okay, so we said Morrison's pouch, okay? The lower part of the liver, higher part, go here near the diaphragm and take a look at the lung and whether there's any free fluid here, okay? Next part, where do we go? Oh yeah, I've promised to show everything with both of the probes so you can see the differences. With this one, what do I see? Do you see that you can also see everything with this one? Yeah, correct? Just the picture is a bit different because the frequency is different, okay? Just use the opposite orientation when you use the same probe to kind of have the same picture on the screen, okay? So here again, kidney, liver, Morrison's pouch, higher part of the liver, then we said this part of the liver and also a bit of the lung, okay? I'll continue on the other side with this probe. So when you go to this probe, compared to the left side compared to the right side, what do you do with positioning of the probe? Is it on the same level? A little bit higher and lower, okay? when you scan for the spleen, go with knuckles to the floor, okay? So if you go here, do you see a structure? I'll sit down so you can see. Do you see the structure? What do I see on the picture? The spleen, yeah, and the kidney-ish, okay? If you are too high up, you're just gonna see one part of the spleen. So just go lower. Do you see me? Like here, I'm literally on the bed. So if you go here, take a look at this space. The trick is that the free fluid is usually not here, okay? In the spleen, really take care of this part of the spleen, okay? Because the free fluid is usually gonna be either here or it's gonna be here, yeah? So it's usually not between the spleen and the kidney. And again, we take a look at the lung as well, okay? If there are any questions, like while I'm scanning, just ask them, and I'll try to reply. Again, with the abdominal probe, what do I see? Let's identify the structures together. So, spleen?
It works now.
Hmm?
It works now.
It works now?
Yes.
Okay, perfect. Like if you want to sit down, you can sit down. If you want to stay here, you can stay here. Like it's really up to you. So you have the spleen here again, and the kidney. Okay? I can wait for you to sit down so before I continue. If you want to stay, that's okay as well. Okay, can you just put this like inside your pants and your pants a bit lower? Okay. Then we discussed about the pelvic area. In pelvic area, we have different anatomies with men and with women. What's different? The uterus, yeah, usually not found in Chris, correct? And the prostate, usually found in Chris, okay? So also the free fluid, where is it gonna be? Because where's the free fluid gonna be inside? Why are we looking at these specific places inside the abdomen? Because these are the lowest parts of the abdomen, okay? How much free fluid do I have to identify the fluid inside? Like 1 milliliter, is that gonna be enough? 100, 200, 500? A liter? Like, who gives more? What do you think? Yeah, like, usually, like, when you have someone that's experienced, that it could also be lower, like 200, 300. But, like, the mean, let's say, number of milliliters in positive fast examination is like 500 milliliters. That's not that little, okay? So again, repeat the eFAST examinations because you are gonna get more fluid if there's active bleeding. Again, when you do this part, don't do the examination here because what are you gonna see? Nothing. You just go, you ask the patient to take the pants a bit lower down and you try to identify the structures. So what kind of structures do we have besides the uterus? What do we see? Like, what's the big black thing there? The bladder, and inside the bladder? There is some kind of fluid, okay? We can't really say, okay, this could be blood. In Chris, we wouldn't expect it to be blood, but sometimes it can be blood. So we can say there is some kind of fluid inside the bladder. Then below the bladder, we have what? The prostate, yeah. And then where do we expect to find the free fluid? Like, look around the bladder, so outside of the bladder, and here in the Douglas space in women, or in the rectopathical space in men, yeah? So, again, when you place the probe, don't be happy with just this picture. Scan it. So, fan it like that, fan it like that. You haven't gone to pee in quite a while, correct? Yeah. What's also really important when you do the eFAST examination, to have somewhat of a full bladder. Because if you have a full bladder, the free fluid is going to be pushed inside the spaces that you're looking into. Okay? So you have bladder, 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 and then here the prostate and the free fluid which is not identified right now. Okay? Again, with a cardiac probe. Okay. I have like 3-4 minutes more. Is that okay? Yeah? With a cardiac probe, again, take a look at this in this projection. And then don't forget to do another thing, which is to turn the probe 90 degrees, okay? To also scan the bladder like that, okay? So longitudinally, like that, okay? And again, with the other probe, it could be like this. Okay? Scan it, scan it, scan it, scan it. Like towards the end, and here again towards the end. Okay? I'm going to ask, is this free fluid? Why not? What do I see? Yeah, exactly, the pulse. Okay? So this is, I mean, it is fluid, but it's not free. It's where it should be. Okay? And then the last part, as we said, is what? To just check the lungs, okay? In the lungs part, I'll show you the pathological part later, where you have to identify, like, what do you try to identify? You try to identify whether there is sliding or no sliding. Where is going to be air? Where are you going to look for air inside the thorax? Like on the higher part, middle part, lower part? Higher part, because air goes up, okay? Sometimes you can also have like a localized pneumothorax, where you're going to have like a spontaneous pneumothorax, but in trauma patients, usually it's going to be higher up, and there's going to be quite a lot of air. What are the structures that you're looking for? What structures do we see here? The ribs, yeah. I want to see if there's like a cursor. Yeah, there is a cursor. So you see like this part here that I'm showing on? Yeah? This is one rib. This is a second rib. And I'm looking at this part here. When Chris is breathing, you can see the small ends traveling like this, okay, up and down. This means that the sliding, there's pleura sliding, so it means there is no pneumothorax. If you would have a standstill afterwards, I'll show you like what it looks like, then this would mean pneumothorax. Again, slide, go to the highest part, always try to picture both of the ribs and the pleural line. You can also see like some small Z or B lines here. Again, you can see sliding when he's breathing. You can see sliding when he's breathing, and move on the other side as well. You have, again, two ribs. You have normal sliding. And what do you have here? What's this? The heart. If you are going to see the heart, and if you see the pulsations like that, there is no pneumothorax here, okay? So this is like one of the major key points that I got, like, because if you see the heart, it means the lung is there for sure, okay? Because you wouldn't be able to see it like that. Again, if you use the different probe, with this one, what do you see? Me, okay? In this one, for pneumothorax, cardiac probe, it's not really good, okay? For me, the best probe would be the linear probe, and you are going to see why in a second. So linear probe. Do you see why I prefer linear probe for the pneumothorax? because you can see it perfectly, okay? And you can also use M mode. I don't use it because like I don't really like it, but this is the what sign? Seashore sign, yeah? If you're gonna have the pneumothorax, you can see like the beach and the sand and the sea, yeah? Okay. If there would be something like this is kind of like a barcode sign, but this is not a proper barcode sign because what am I scanning right now? The rib, okay? So you have to be placed here so you can scan the lung, okay? So when you scan the lung, go here in the anterior line on the right, on the left side, and then also on both of the sides here. Yeah? Thank you very much. Okay, so can I just like jump back to the presentation a bit? And then I'll finish so you can go and get some hands-on experience. Perfect, thanks. So just a quick recap on what we took a look at. So we took a look at the pericardium, whether it's free fluid or no. We take a look at the right upper quadrant. This is what I've shown you inside the ultrasound. We took a look at pelvis. Left upper quadrant was missing from my presentation. I don't know why. I probably deleted it by accident. This is what I wanted to show you for pneumothorax. Do you see it on the right side? Like there is no moving. You can definitely see no B lines or Z lines, which are the small B lines. And you can see no pleural sliding as we saw in Chris, yeah? And this is the M mode, so with seashore sign or barcode sign. Just like a quick thing to think about on where you're gonna have problems with your FAST examination. First of all, FAST is not good for solid organ injury. So it's not really specific or highly sensitive for that. It's also not very specific or sensitive when the bladder is really empty, okay? Then what else? Sometimes you can have a false negative, we talked about. If you have a high suspicion, then repeat the examination. And sometimes it can also be false positive. So if you have someone with liver cirrhosis and an ascites, this might not be a sign of trauma, okay? And the acoustic window is not like really good. Like if you don't fan it well, if you don't manage to see the structures well, in polycystic kidney, you're gonna have quite a few problems because it's like really different shaped and different sized. The bladder we talked about. And again, in the obese patients, the problem could be with kind of when you try to position your probe. But sometimes they can actually surprise you because sometimes when I see someone that's really obese, I'm like, fuck, this FAST is gonna be really difficult to do. And you can see everything perfectly. So like just don't be prejudiced too much with this. But the problem is sometimes that you have some epicardial fat that could appear to be free fluid inside the pericardium, okay? Especially in obese patients. Then again, operator knowledge. Okay, this is dependent on you, like how much do you scan and what kind of things you identify. And the more you're gonna scan, the better you're gonna be. The more pathologies you see, the better you're gonna be. So what you can do about it is just to kind of practice, practice, and practice, okay? I've also written down the fluid echogeneity. So we talked about like the different different types of fluids inside the bladder, or let's say inside the pericardium. So take a look at this. We'll take a look at this at the cases. So this would be it for me for now. If there are any questions. No, perfect. Then that's it. Thank you very much for your attention.
So thank you very much for your very nice talk. We will now have our hands-on sessions till 11:30, where you can practice all what you just heard. And during the hands-on sessions, we have two very exciting workshops taking place in the seminar rooms A1 and A2. Your tutors, they know when your time for your group is, that you can go there. And group 1 goes directly to A1 now, and group 7 goes directly to A2 now, please. And yeah, so have fun, and see you later here at 11:30 for the second part of the talk. Have fun.